This is how Black people get killed when you send them home and they don't know how to fight for themselves. The quote that I just read was by the late Dr. Susan Moore, who was a physician from Indianapolis, Indiana, who died due to complications relative to COVID-19. Just 2 weeks after she was prematurely sent home with inadequate pain treatment and poor execution of service from her primary provider and caretakers at that time. Some of you might have already been familiar with this case. It was pretty prominent in the news last year. But something that came up in her story after reviewing details related to her case was the presence of racialized bias about Black patients and opioid use. This was reported by her in a number of videos that she recorded to document her experiences, as well as feedback from some of the colleagues of the physician who was accused of this. And some of you may be wondering, why am I even talking about this? What does this have to do with today's topic? And in a moment, we're going to talk a little bit more in depth about how the presence of social and political power plays a part in the level of control one has over their health. Hi, my name is Dr. Dennis Daniels. I'm clinical assistant professor in the Division of Health Services Policy and Practice in the Department of Epidemiology and Environmental Health at the UB School of Public Health and Health Professions. My pronouns are he, him, his, and I want to thank you all for joining me as we discuss in two parts, this being part one of health equity, disparities, and reform. We're going to talk a little bit about why we should care to discuss health equity in public health, political, and health science related discourse, as well as look at how history into the present can illustrate to us a number of inequities in our society that deprive all of us of a fair and just opportunity at a healthy lifestyle, and then talk about a number of social and political barriers that deprive us of attaining health equity as a society. When I'm talking about health equity, what I'm really describing, as I just mentioned, was everyone having a fair and just opportunity to be as healthy as possible. And this requires removing barriers to equitable health, such as poverty, discrimination, social stigma, and powerlessness, a lack of affordable employment and fair pay, quality education, clean air, adequate housing, and accessible, affordable, and adequate health care. Those groups who are often given the short end of the straw when we have discussions about these social factors. We're talking about marginalized populations. Marginalized populations or marginalized communities, those groups relegated to the lower and peripheral edges of society, whom are often denied full participation in mainstream cultural, social, political, and economic activities. They're often subjugated to the dominant class in our society, or dominant classes in our society that have political, social, and economic power to control their lives and many times have a say in the lives of other groups. And so when I'm talking about marginalized or underserved communities, I'm describing those who would be described as members of protected classes under federal law. So these are peoples of color, women, the LGBTQIA plus community, the elderly, individuals with physical and or mental disabilities, the homeless, and a number of other underrepresented communities in our society. So why should we care to discuss health equity? Well, there's a number of reasons, according to the CDC. Many social factors we need to consider that can impact health outcomes across populations and deprive those with less power and privilege the ability to have more control over their health. So when we look at our US Constitution, when we look at many of our federal laws and hear rhetoric among politicians pursuing representative positions of power and authority in our society, we hear concepts like liberty, justice for all, fairness, equity. These are values that are very central to American society. And so when applying those values to public health and healthcare, what we're really doing is we're talking about health equity. We're talking about everyone in our society having access to basic health promoting resources, and this not just being afforded to a very select few privileged individuals. And so, this is really the heart of health equity and why health equity needs to be a priority. When we look at many chronic conditions and statistics, data related to many chronic conditions in our society, we notice that marginalized populations suffer from these chronic conditions at higher rates than their majority population counterparts. This is something that we have to strongly acknowledge and be cognizant of. Approximately 9% of the American population is uninsured, and this statistic is continuing to increase according to the US Census Bureau. A large portion of our uninsured Americans are ethnic and racial minorities. 73% of underinsured Americans are below 200% of the federal poverty level. When we challenge these barriers that present health disparities or preventable and inequitable differences in health, we have the ability to attain health equity through reform efforts. But in order to achieve effective reform efforts, we need to recognize the barriers that deprive us of health equity. So what are those barriers that prevent health equity? There are a number of social factors, according to the CDC, that impact health outcomes. Examples include food insecurity. East Buffalo, as many of us who are familiar with the area, familiar with the city, has been considered by many data sources to be a portion of the city where it's been difficult for residents to access sources of nutritious and affordable food. And this has been shown to yield negative health outcomes among many communities who reside on the east side of Buffalo. When we look nationally at food insecurity and the negative impacts it can have on health, over 42 million Americans experience food insecurity. 13 million of them potentially are children. And a number of health outcomes such as obesity, type 2 diabetes, and a number of other chronic conditions are related to food insecurity and not having access to affordable, nutritious food. Unsafe and inconvenient transportation. When we look at data related to who had the greatest amount of complications arriving at clinics recently to receive both doses of COVID-19 vaccine, those who previously depended on public transportation to get to clinics for service and were then unable to do so due to mandates that shut down a lot of our public services at the time, had challenges in doing so. This also extended to disruption with routine clinic visitation for those who were underprivileged and elderly, those with chronic conditions and unable to attain convenient and consistent transportation, had disruptions in their service. When we look at rural communities where access to different buildings and facilities are very limited compared to urban communities where things are a lot closer together, proximity matters here, right? We can notice that this can be a barrier for those who don't have transportation, getting to clinics, getting to outpatient facilities. These can be challenges that do impact health outcomes. Air pollution. Again, looking at Buffalo's east side, we see higher rates of asthma and a number of other respiratory conditions when compared to other parts of the city. We also notice that air pollution is higher on this part of this, higher in this part of the city. And so health outcomes related to air pollution are noted here. Unsafe and unstable housing. Children from violent neighborhoods are more likely to experience inconsistencies with physical activity due to being in neighborhoods where conditions are unsafe. So in lack of education, statistics show that the higher one's education status, the more likely they will not only have access to healthcare coverage, but utilize that healthcare coverage to attain a satisfying lifestyle and level of wellness. When we look at social stigma and discrimination, history shows over a period of generations how research injustice, exploitation among marginalized groups historically have led to generations of distrust of the healthcare system, and even among affluent members of historically disenfranchised groups, such as many African Americans, Asian Americans. This has led to underuse of healthcare services. And so, these social factors can impact our health. And it's barriers like these that deprive us of health equity by presenting a number of disparities or preventable and equitable differences in health. So getting back to power and privilege, I said a moment ago that the more power and privilege one has in society, the more control over their health and lifestyle they have. Let's look at how history has shown to us the effects of a lack of power and privilege, and not just the effect that it's had over the health of individuals then, and certainly, as it does today, but also look at how exploitation among the historically disenfranchised has led to generations of distrust of the US healthcare system, and unfortunately yielded a number of service underuse outcomes that we notice among these same groups.
Silence and solitude. Lily Tyson Head needs a bit of both right now, as she reflects on the trauma of her family's past, while leaning on faith in the future.
Things have changed. Things have gotten better, but still needs to get a whole lot better.
All week, celebrations across the country hitting a fever pitch as the new COVID-19 vaccine begins to arrive. This long-awaited moment providing hope for so many amidst the pandemic. A study by the Kaiser Family Foundation found 71% of Americans say they definitely or probably will get the COVID-19 vaccine. But Black Americans are far more hesitant. 35% say they probably or definitely will not get the vaccine.
So I want to know how much of the people who are doing the trials of the vaccine are African American.
I'm still on the fence about the actual vaccine. In the African American community, we never really received anything that's going to be beneficial for us in the beginning.
That distrust is well earned. Lily's father was an unwitting player in one of the darkest chapters of our nation's history.
My father was Freddie Lee Tyson. My father is our hero.
A sharecropper in Alabama in 1932, Freddie Lee Tyson was one of 623 black men recruited into a medical study. We now know it as the infamous syphilis study at Tuskegee. Freddie thought it was a program to provide free health care. He had no idea that the doctor's only interest was to study the infection he had been born with.
They did not tell them they had syphilis, and the only thing they told them they had bad blood, and they were treating the bad blood. But they were not. They were lying to the people.
The study was run by the U.S. Public Health Service, white doctors hoping to chart the natural progression of syphilis in black men.
What did your father think he was participating in?
I would say that they were looking to better their health and to better their conditions. He did not know that he was in a study. He did not know.
The government went to extremes to keep it that way. Even when penicillin became a safe and reliable cure, the study doctors actively prevented the men from getting it, circulating secret lists asking health providers not to treat them. When some of the men were drafted into World War II, the researchers had them rejected from the Army, so their syphilis would not be treated.
Talk to me about the misinformation surrounding the study.
Some people, believe it or not, still think the men were injected with the virus. They were not.
The truth about the study didn't surface until 4 decades later in 1972, when a whistleblower outed the experiment.
When the CDC first called him, he was quite upset. He was angry, and I also saw some shame.
Shame? Say more.
Shame because he had been deceived. Now you have to understand, my father was a proud man, and he was honest.
And our government treated him like a lab animal.
Right. These men deserved better. Their dignity was taken away from them. The basic human needs of a person was stripped of them.
So there you have it. And special thanks to the descendants of Freddie Lee Tyson for being vulnerable and sharing this information with us. So what does history show us about why there is distrust among many historically disenfranchised communities towards the U.S. healthcare system? It shows us that the exploitation, abuse, and research injustice that took place over a period of generations historically to very recently have caused negative attitudes and underlying beliefs about the healthcare system and led to a poor relationship with the U.S. healthcare system and potentially underuse of services among those who even have access to healthcare and health promoting resources. And this is problematic because this too can yield negative health outcomes, what we're trying to challenge, in addition to a number of accessibility disparities. The Tuskegee syphilis study was what was the focal point of the clip that you just saw. And certainly in discourse revolving around the COVID-19 vaccine, threaded in the rhetoric of those who are skeptical and distrusting of the vaccine and its effects on them, many of them have cited the Tuskegee Institute syphilis experiment or the Tuskegee syphilis study, where, as you heard, 600 plus Black men, many of whom were sharecroppers from Macon County, Alabama, volunteered for the study, being told that they were going to be given free healthcare, something that many sharecroppers and many of the underprivileged in the rural South did not have access to, and to be treated for bad blood. They weren't quite as familiar with syphilis. Many participants actually had Yaw's disease, which is a bacterial infection very similar to syphilis. But nonetheless, they were to be treated for this condition and ended up not being treated for the condition because the underlying objective associated with this study was actually to track progression of untreated syphilis in participants. This is not just dishonest and unjust, but it is very malicious. And that's why this study is very infamous and often cited as a reason why later supervising entities over research, such as the IRB and a number of other supervisory and governing entities over research, especially in medical and public health contexts, exists to make sure that consent is at the center of any kind of participation of research. Consent actually is required. Informed consent is required before any participants are permitted to proceed forward in studies, as well as being informed of what the benefits and the risks are associated with participation. That's something that was not granted to any of these individuals, and why the majority of these participants unfortunately died due to untreated syphilis. And so, a history of marginalization and exploitation play a major part in the current distrust among some underrepresented groups, marginalized groups in our society. And this, as I said before, can lead to an underuse of service. Something else to note here, in addition to distrust towards the healthcare system, was to note the bias in the researchers. Some of you may be wondering, how in the world could an individual or group of individuals lie to over 600 participants by telling them they're going to receive free healthcare, knowing that they were deprived of healthcare access, and then let them die from syphilis? How could you bring yourself to do something like this? Well, there is an underlying ideology related to that kind of action as well. Certainly when we look at history, much of the 18th and 19th centuries, and beginning 20th into mid 20th century, we see many reports of documented literature really promoting pseudoscientific bigotry known as scientific racism. And this led to generations of bias among the practitioners and the researchers who took part in a lot of these studies that we read about. Harriet Washington unpacks this conflicted history between the American healthcare system and the historically disenfranchised in her text, Medical Apartheid. And if you look at chapters 1 and 2, and even look at really the first 9 chapters, you can see many examples of research injustice, non-consensual medical experimentation, and exploitation of African Americans by physicians and other medical science researchers. And a lot of the ideology behind this, and really used to justify it at the time, were scientific racist beliefs. And again, this is scientific racism is a pseudo-science attempt to justify racism by concluding that whites, the epitome of humanity, compared to Blacks, Irish, those with mental disabilities included as well, because they weren't considered white during this time as well, which were considered to be subhuman and therefore not capable of feeling pain or being able to process information to the degree that their white human counterparts were. And so this bias and bigotry in medical practice led to the abuse, exploitation, and misrepresentation of African Americans, in addition to individuals with physical and mental disabilities, immigrants such as Irish immigrants, Italian immigrants, as well as women. Women were also deprived. If we expand this a little bit and look at bigotry as a whole that was practiced between the 18th to mid 20th century, we can see how there was exploitation, abuse, and misrepresentation in medical science of these marginalized groups. And so bias and bigotry not only deprived these individuals of having a fair and just opportunity at a healthy life, but it deprived them of being properly informed of procedures that during the 20th century they unconsciously volunteered for. And when we look at the 18th and 19th centuries, they were forced into. Certainly when we look at enslaved Blacks during the 18th and 19th centuries, there was no consent, there was no attempt to manipulate or deceive them. They were forced into it because only the consent of the plantation owner was required. And so, this practice of oppressive habit among healthcare providers towards underserved patients, subjects, due to bigotry, led to a lot of negative outcomes. Certainly we look at abuse and exploitation, but then later, generations later, distrust towards the healthcare system. So that's the role that history played in showing us how a growing distrust can lead to underuse of service, certainly when considering the attitudes and beliefs among historically marginalized groups. But looking at social and political factors overall, if you don't get anything else from this, please understand that social factors do play a part in determining health outcomes because they can serve as barriers if we're deprived of power and the ability to attain a healthy lifestyle. I want you to take a look at this visual to the right of your screen. This is the US population according to the US Census. We can see through census data and data from a number of other sources, we're continuing to grow more diverse today. And this is great. Society is becoming more diverse. Even amid the pandemic, we're still seeing progressions towards diversity. At the same time, we need to realize that certain population groups still face greater challenges than others, which can yield a greater risk of poor health for those who don't have a fair and just opportunity at a healthy lifestyle. When we look at our national population, currently 18.8% of Black Americans live below the poverty line. When we look locally, 29% of Buffalo residents live below the poverty line. That's $11,770 a year for a single person, and approximately $25,000 a year for a family of 4. Children are at the greatest risk when it comes to noting the negative outcomes associated with poverty. When we look at malnutrition, when we look at unstable housing, when we look at pollution and poor air quality, access to affordable and adequate healthcare. These are things that the American poor are often deprived of. And then recently, we're seeing accessibility issues and accessibility disparities among the lower middle class. These are individuals who are either underinsured, where they have some form of coverage, but it doesn't completely meet the needs of these individuals, as well as those who don't qualify for public coverage, such as Medicaid healthcare programs, and cannot afford private healthcare coverage. And so there's a dependence on charity care that's provided through service through a number of public health program efforts, as well as volunteering from service providers in order to meet their needs. And that's highly inadequate when we look overall at what those needs are long term. We have to also consider how maldistribution, with consideration to the healthcare workforce, can present a number of accessibility disparities. Currently, 20% of our national population is attributed to rural America. Rural communities present a high number of workforce shortages, as many of you have noted from your readings previously, and this can yield a number of disparities relative to mortality and morbidity, and certainly recovery from chronic conditions among many Americans, certainly the elderly who live in rural communities. And so in many cases, the rural poor is very vulnerable and unable to really have control over their health and their quality of life. So I want to thank you for tuning into part one. To review, health equity is an assurance that all have a fair and just opportunity to be as healthy as possible. CDC tells us, in addition to a number of other sources, that income, class, age, location, discrimination, the presence or lack thereof of power and privilege can impact a variation in health outcomes and either allow us or inhibit us from having control over our health. The more privileged one's status is in our society, the better opportunity at a healthy life that one has. Also consider how the experiences of abuse and exploitation, as well as current attitudes and beliefs among individuals, especially those who are marginalized groups, can occur and are, and certainly take them into consideration before effective reform efforts can be achieved. We can't achieve health equity until we challenge the barriers to equitable health. Stay tuned for part two as we talk a little bit more about frameworks, conceptual frameworks that are in place to help us better understand health equity and how we've challenged health and equity over the years through reform efforts.